You call.
Good morning. It's a Sunday morning, last day. There were several factors for the cause of the thin attendance. But there is an exciting program which is ahead of us. The Dr. Ramya, so if you see the list, Ramya is not there to have an introduction overview. So we will go directly to the grand round of the COVID and rheumatism. This session is a theme, real life challenges, microbes and rheumatism. Shall I call Dr. Pooja Srivatsava from Lucknow, please?
Good morning, everyone. So I'll be speaking. I would thank the Iracon organizing committee for giving me this opportunity to actually revise COVID. We had become very relaxed over the last 6-7 years, and we thought that it probably is over. So overall, the interaction between SARS-CoV-2 and autoimmune and rheumatic diseases, it is an interface between the host immune landscape, which medicines the host is on, and the effects of virus on the pre-existing immune disease state. And the interplay between two actually decides the outcome of patients. So in last 3 years, what we have seen is both the COVID and the human race, they have been playing hide and seek game. Once COVID comes up with some new variants of concern, and then we develop a new drug and mechanisms to deal with it. And somehow this hide and seek game has been going on for last 3 years, and the virus has now moved from pandemic to an endemic stage. So I would try to answer questions on COVID and rheumatism on a case-based method. And so we moved to our first case. This was a 35-year-old lady who presented with low-grade fever for 8 weeks, mild cough and grade 2 dyspnea on exertion for 4 weeks. And there was history of transient rashes on arms and arthalgias in hands and feet. She had history of moderate COVID-19 disease for which she required 5 days of admission and received a short course of steroid and remdesivir. She has history of hypothyroidism, which is in good control and treatment, and she has a family history of rheumatoid arthritis in her elder sister. So what would be the differentials in this patient? Does she have long COVID? Is a new autoimmune disease triggered in her because of the recent COVID infection? Or it's just a coincidence that probably a new disease was already coming in and at the same time she developed COVID? So there's no clear answer to it. Further research and a very close follow-up can truly answer the question. We have seen that there's a condition called long COVID syndrome, and many symptoms and manifestations are being fit in that. So what exactly is this long COVID syndrome? It's basically the time lag between microbiological and clinical recovery. So once the microbiological recovery has occurred, the patient has become PCR negative and there are persistent symptoms of various organ systems, that is considered and is being observed and studied as long COVID syndrome. And there are a lot of manifestations which are attributed to post-COVID thing. The most common, which probably affects almost all organ symptoms, and the most common one which we all came across in the 2020s and 21 was the multisystem inflammatory syndrome, both in children and adults. So both had a case definition of multisystem inflammation with raised acute phase reactants. But the most important part to think there is this was to be labeled only when there was no alternative plausible diagnosis. Not everything, each and every symptom which occur after COVID is post-COVID. We should first investigate all the plausible causes, and then if we don't find anything and we have a positive or a history or a strong report that patient had a recent COVID, then probably it can be attributable to COVID. So most traumatic manifestations after COVID which we see is articular symptoms which range from arthalgia, acute arthritis or chronic arthritis, lymphocytis, myalgias, some drug-induced like favipiravir-induced hyperuricemia, and these things have been reported from the tune of 2.5 to 31%. There was worsening of baseline diseases was noted. Few reports of new diseases triggered with the COVID was also reported. But the good points are that most of these symptoms were transient and resolved with short-term steroids or NSAIDs. Few required methotrexate, DMARDs or other immunomodulatory drugs. This was a case report, this was a study case series from Kolkata, where they reported 23 patients with reactive arthritis happening within a month of COVID infection. Knee was the most affected joint. They couldn't do B27 and SI joint imaging in all the patients, but 2 out of 3 had B27 positive. Most responded to short-term steroid. Only 3 required steroid and NSAIDs, only 3 required methotrexate. So again, here also a direct causative role could not be established. Now, reports on myositis. Our patients could have this also. So both, it could be either virus-induced muscle damage or virus-triggered autoimmunity. Varied presentations have been seen from mild presentation to only paraspinal muscle affection to polymyositis, dermatomyositis and rhabdomyolysis. The ethopathogenesis can virus-mediated muscle damage via entry via the ACE2 receptor, or it could be just the immune trigger with the COVID infection. A stark similarity has been seen between MDA5 positive myositis and COVID-19, and it is now being considered that probably COVID-19 could serve as a human model for anti-MDA5 IIM. The similarities are acute interstitial pneumonia, vasculopathy, thrombosis, cytokine storm, fever and hyperferritemia, pneumomediastinum, which was very commonly, specifically seen in COVID-19, and the ILD pattern, bilateral posterior and peripheral ground glass opacities. So the MDA5 could serve as a common link for the etiopathogenesis. It's an intracellular cytoplasmic viral RNA detector which triggers interferon response. Then coagulopathy. We all understand that COVID was a prothrombotic disorder, and DVT, PT, acute coronary syndrome, CV strokes and BIC have been reported, and autopsy findings have also shown microthrombosis in multiple organs. In severe diseases, COVID-19 can be compared with catastrophic APS syndromes also. But the mechanism of coagulopathy in COVID is multifactorial. It could be thrombotic microangiopathy, sepsis, or inflammatory syndrome related BIC, antiphospholipid syndrome, or just progression towards HLH mass. Regarding antiphospholipid manifestations, all the 3 antibodies have been reported. Lupus antibody from 3 to 92%, non-criteria IgA beta to GPI from 0 to 37%, and anticardiolipin from 0 to 30%. Most of these antiphospholipid antibody titers were transient, fluctuated, and turned negative within a period of 1 or 2 months. They were not associated with clinical thrombosis. Patients with pre-existing COVID, some flares were reported. But like any other infection-associated antiphospholipid, the COVID-related antiphospholipid was also transient and improved. This was a study from Italy, where 150 healthcare workers, once vaccinated, were followed up for up to 12 years, and there they were studied for antiphospholipid antibodies, ANAs, antithyroid antibodies, and antibodies against human proteome. And some sporadic positivity was seen, but all the subjects who resulted positive of these antibodies remained asymptomatic during the study period. So we can conclude that vaccine also doesn't trigger antiphospholipid antibody production. Now coming on to our second case, the routine garden variety patients coming to OPD. This was a psoriatic arthritis. So first patient, what happened to her? The first patient, 35-year-old lady with joint pains, little rashes, and thin. She finally turned out to be a myopathic MDA5 positive myositis. Her main presenting the symptom which is driving the treatment is the interstitial lung disease and bit of arthalgia. She's doing good on mycophenolate 2 grams per day, and steroids have been taken to 5 milligram, and she's under follow-up. The second case is a psoriatic arthritis patient who is currently having a low disease activity on combination DMARDs. He has received 2 doses of adenoviral vector vaccine, the Covishield. The last dose was in July 21. He has seen these reports yesterday night on the news and social media that China is imposing fresh COVID curbs. Big Omicron spike is there. Japan is reporting cases more than 1 lakh per day. And the China COVID numbers are almost comparable to the previous wave. Probably it's rising. And there's a talk about a new variant. So his queries are, he has an international travel to do in the next 2 weeks. He has come to consult with these queries. What is my risk of developing a new COVID infection? What should be done if a new COVID develops? What should I do? What is the efficacy and safety of the vaccine, and should I be taking a new COVID booster? And what is the likelihood of post-COVID disease flare? So to answer these questions, we can show him the data which is available. This was an Indian data from March 2020 to December 2020, multi-center data collected across the country, and they found that at that time the policy was to admit everyone. So mortality predictors were other comorbidities like diabetes, hypertension, severe dyspnea and presentation, high neutrophil count, and patients who were on rheumatic disease who were on a very high doses of steroids, like more than 20-25 milligram per day. And overall mortality was comparable to the general population. It was not that the patient of autoimmune rheumatic diseases had higher morbidity or mortality. This was another study where 9,212 autoimmune rheumatic disease patients were followed up for around 5 to 6 months from 15 rheumatology centers, mostly in Western India, where it was found that patients on these drugs, 3.5% patient developed, and the risk factors for poor outcome in these patients were older age, male gender, smokers, hypertensive or diabetic status, and condition of underlying lung disease. They have reported the case fatality rate was higher in patients with autoimmune rheumatic disease, both from Karnataka and Kerala, as compared to the general population. Here to note, the general population data was taken from the government reported cases, and we can all think how the numbers were. So we have seen MISC and MISA post the Delta variant. This was a study in Lancet just this month only, which showed that the frequency of long COVID was much less after the Omicron variant as compared to Delta variant. And the Omicron cases were less likely to experience long COVID for all vaccine timings, whether they have received vaccine for more than 6 months, 3 to 6 months, or even 3 months. The chances of long COVID after this was higher. So what if this patient develops COVID? He should follow COVID line. He should take a booster dose, and if he should not be stopping his DMARDs, and if he develops a serious disease, he should consider pre-exposure prophylaxis with monoclonal antibodies. If he develops a mild disease, probably antivirals can be considered like molnupiravir or remdesivir. For severe disease and for a mild disease, he should withhold the DMARDs for 2 weeks. For severe disease, he needs to get hospitalized depending on his severity. Medicine demands would be stopped in the first week, and depending on the severity, dexamethasone iron inhibition can be planned, and it should be balanced to avoid infections. Vaccine-induced immune responses and his baseline drugs. So this we have been following for last 2-3 years. The drug which is to be avoided, which affects both the B and T cell response, is rituximab. The drugs which can modulate little bit is methotrexate, mycophenolate, and JAK inhibitors. The TNF blockers, IL-17 blockers, IL-12 and 23 blockers, they don't have much effect on vaccine, and their dosing should not be adjusted. They require no change prior to booster vaccination. What about the safety of vaccine? So vaccination has been the strongest weapon against this fight against COVID-19, and this was a data from 30 countries of more than 5,000 patients who were vaccinated with either mRNA vaccine or adenoviral vaccine, and the breakthrough infection in completely vaccinated people was just 1%, 37% possible probable adverse events, less than 5% had severe adverse effects, 4% disease flares were reported. They were mostly MSK symptoms, only 1.5% required change in dose or a new medication. This was vaccine efficacy data where the Covishield and Covaxin was compared, the two vaccines which was available in our country. And it was shown that patients with autoimmune rheumatic disease had lesser titer of antibodies as compared to general population. But the difference was only like 90% in autoimmune rheumatic disease versus 97% in non-autoimmune rheumatic disease patients. And the antibody titers were also higher, and the point to note was patients who were vaccinated with Covishield had much higher antibody titers as compared to Covishield. So probably if the question is asked which vaccine, in our country we would recommend Covishield because mRNA vaccines are not available here. Hybrid immunity, this was another study where they compared different immune seroconversion titers in patients who had single dose, double dose, infection and double dose of vaccine. So patients who had both infection and vaccine had much higher antibody titers and had higher neutralization capacity for virus in vitro studies. So probably most of our population has a hybrid immunity. Most of them have received at least one dose. And with the new wave coming, probably we should be recommending a booster dose. So regarding the vaccine adverse events, vaccine-induced thrombocytopenia and VIIT has been reported, but the frequency for this is less than 1%, less than 1 case per 1 lakh, and it's more of a side effect which happens. So for most symptoms can be controlled just with a paracetamol. Patients who develop severe chest pain, shortness of breath, palpitations, leg swelling or persistent swelling in leg, those patients should be, their VITT should be considered, and appropriate treatment should be started as early as possible, that is mediated by platelet 4 antibodies. But for large majority of people, including those with vascular disease, the benefits of COVID-19 vaccine greatly outweigh the risk. Vaccination is safe and still remains the best way to limit COVID-19 spread. So final answers to the patient would be most traumatic symptoms are transient, short-lived and self-resolving. Risk and outcome of COVID-19 is almost comparable in patients with autoimmune rheumatic disease, except those who are on a very high doses of steroids or those whose baseline disease status is bad and has organ dysfunction. Vaccines should be encouraged. Vaccines are safe and efficacious, and a booster dose is recommended in patients with autoimmune rheumatic diseases. Risk of disease flares is very low and is easily manageable. So what we have in future. Will COVID end in 2022? Very unlikely. It has moved from pandemic to endemic. We have to live with this, and overall functioning of the community will depend on the community immunity index. So we should all press for vaccination. And the virus is also very smart. It will play with immune evading new variants. So the next year will decide if the virus mutates to a Delta clone, that is infectiousness of Omicron with severity of Delta, or it mutates to a milder Cron. That is infectiousness of Beta or Gamma variant and with severity of Omicron. So for now we stand as bystanders and the battle is totally not over. We'll see a lot more with this virus. Thank you.
Thank you, Pooja, for the nice lecture, and your grand round was very nice. And I mean, there are a lot of questions which comes to the mind, and we will take it later on. Thank you. Now I will invite Dr. Ingrid Lundbach from Sweden for her expert comment and final verdict. She will give us light what to do in COVID.
Yeah.
Good morning, and I congratulate Dr. Pooja for a very nice presentation. And I totally agree with you on your comments. And what I think we as from the rheumatology community should be aware of is the risk of our drugs that we use, in particular rituximab, which has come out in the large registry study, among others from Sweden, where I think we need to be aware of the low antibody response after vaccination in patients with rituximab. And I heard the debate yesterday between cyclophosphamide or rituximab, and I think that is very relevant in this context. And we should be careful in how we select the patients for rituximab, and also how we organize the timing between the rituximab infusion, because in some patients it's really the drug of choice, and how we can improve the result of the vaccine how long we wait between the infusions and the vaccination. I just prepared a few slides because I was not aware of that I should discuss this, but my major comments is what I have said. And what I think is also relevant for the first case as we presented with that turned out to have developed MDA5 positive dermatomyositis. And as Dr. Pooja already presented, the muscle involvement is very common in patients with viral infections, including COVID, both with pain, weakness, and even rhabdomyolysis. And then the question is if you can also develop an autoimmune disease after this infection. And I think we all hear about patients like the one you presented that have developed an autoimmune disease, including dermatomyositis, sometime after the infection. And I now searched PubMed for cases, and I found in total 13 reported cases with dermatomyositis of COVID. And they had various presentations. ID was present in half of them, and they have various autoantibodies. But I think the most important message here, like with your case, is that the outcome was favorable in most cases, which is maybe different from where we don't have as we believe, an underlying infection behind. But it's very unclear if they are at all associated with the infection of COVID, or it's just by coincidence. And then also the question whether you develop autoantibodies after the COVID vaccination. And here there are again very conflicting data, and I think it's important that we compare to the population and also what Dr. Pooja presented and follow up what happens with these autoantibodies, because it's quite common to develop autoantibodies after infections. And I just here present to you there was one report from China, this one, where they tested for autoantibodies, including the anti-MDA5, in hospitalized patients with COVID-19, and they reported that 48% of their patients in the hospital actually had MDA5 positive, were MDA5 positive, and those patients had a more severe prognosis. And then there have been a couple of other studies with lower number of cases but where they did not see an increased number of MD5 or other autoantibodies compared to population. So I don't think we know this yet, and I think this is a question we need to follow up, in particular if you develop disease or if they are only asymptomatic. The other question is whether the vaccine induces autoimmune disease. And then there are a couple of reports in relation to myositis. And I just show you one here. This is from the UK, where they identified in Yorkshire a cluster of new onset myositis after the vaccine. And you can see they had 9 of them had received the AstraZeneca vaccine and 6 had received the mRNA vaccine. And they developed different types of myositis. 3 had interstitial lung disease, 3 skin rash, and they had various autoantibodies. But again here, the outcome improved with commercial treatment and even spontaneously in 2 cases, and 1 patient died. So there is a temporal association, but the question is there a causality? And that we cannot answer by this. So concerning the relation between COVID-19 and myositis, I think we can conclude that muscle symptoms are frequent in patients with COVID-19 infection, but unclear if COVID induces or it could be a risk factor for myositis. And the autoantibodies associated with myositis do not seem to be more frequent after a COVID infection, but conflicting data. And regarding the relation to vaccination, I think we don't have the answer yet. And I do agree with Dr. Puja that we should really encourage our patients and their families and the population to be vaccinated, because I think that's the best we can do now, and in particular to protect those that have a severe underlying disease, like kidney disease, which is a risk factor for severe lupus, or interstitial lung disease. And again, the MD5, as Dr. Puja mentioned, the similarities between the MD5 associated DM and SARS-CoV, if this could be used as a model, and I think that needs to be explored. So those were my comments. I have to stop there. Thank you.
Thank you. Thank you, ma'am. Now I invite Selva Kumar from Chennai. He will talk about Balamina, Selva Kumar from Chennai. He will talk about HPV vaccination for RMD patients.
Good morning all, and the outset I would like to thank the organizers of the scientific committee for giving me this opportunity to be with you. So we all know about the human papillomavirus producing both genital warts and cancers of the genital tract as well as oropharyngeal cancers. Just to freshen up, what is the need of HPV vaccine in general and HPV vaccine in rheumatic diseases. Because at the outside the world, there is some data facts that has to be analyzed. Cervical cancers are cause of leading death, 1/3 of the leading cause of death in women, second to breast cancer. Out of 500 women detected cancer in near 80% of developing countries, 275,000 die annually because of cancer. And though pap smear done periodically helps in identifying cervical cancers at the early stage, we have to know about the association of human papillomavirus in each individual. So because they are producing 90% of the cervical cancers along with the oropharyngeal cancers and penile cancers in male. So the syndrome will be from clinical scenario from genital warts to cervical cancers. So introducing the HPV virus, there are 200 related virus groups along with the HPV. and 100 producing genotypes are identified. Out of that, 40 types spread through direct sexual contact. And they are, what are they? They are a group of DNA viruses, and genotypes associated with genital warts are types 6 and 11, whereas 16 and 18 types are produces 70% of the cancer service predominantly, other than the other oropharyngeal cancers. So what is the structure of papillomavirus? They are small, non-enveloped, icosahedral DNA viruses that have a diameter of 52 to 55 nanometers. The viral particles consist of a single double-stranded DNA molecule ranging up to 8 K base pairs. It's bound to cellular histones and contained in a protein capsule composed of 72 pentameric capsules. This structure has to be needed because it enters into the cell, and because of the DNA molecule, it persists inside the cell and producing cancerous tissue. So is papillomavirus circular or linear? It's circular, and all HPV are non-enveloped double-stranded DNA viruses. So they have a free entry into the cells. So this is the EM view of the virus. And what are the stages of human papillomavirus cancer stage? Can be divided as 1, 2 and 3. The first is in precancerous or carcinoma in situ condition, whereas second will be because of the persistence of HPV virus and causing overt cervical cancers, and third will be the spread of the cancer cervix, spread away from the cervix and into the surrounding tissues in the pelvis, may or may not have spread into the pelvic lymph nodes. It might have grown down into the lower part of the vagina and muscles and ligaments in the extended state, into the pelvic wall. So how long it takes for the change can be from a few years to 20 years maximum, and that's why the need for the vaccine in the before the second decade or in the adolescent period. So what can you do to protect yourself from cervical cancer? So HPV spreads through sexual contact, and they have found that in US population, 47% of sexual contact occurs with high school children, and about 6% even below 13 years. So to protect yourself from this, they are giving barrier method, and other than that, we have to vaccinate these children. So evaluation of HPV virus effects is just genital warts, how they present, flat, raised, single cauliflower clusters. This to identify the clinical scenario. And genital warts usually appear as small bumps. They can also extend into the surrounding tissues and skin also. If you get a Pap test alone every 3 years and HPV test alone every 5 years, or a combined Pap and HPV test every 5 years, you can identify the individual and the need for the HPV vaccine. So to detect cervical cancer at an earlier stage, see your doctor for a regular Pap test beginning at the age 21. This is in vogue throughout the world, and seek prompt medical attention if you notice any symptoms of cancer cervix, and like vaginal bleeding after sex, between periods or after menopause, and vague dull pelvic pain. So these were the periods. The course of HPV infection. So there is no evidence that HPV has triggers like herpes. So in the follow-up of HPV, but they can be silent, or they can because of the human immunity they can fade away, but they can persist in certain individuals genetically preponed, or whether they are immunocompromised and go for persistence of infection into the cancer stage. So treatment is multiple available for the genital warts. So the mycelial extract, they are given as in oral preparation, up to 500 milligrams, up to 3 grams, they are given in many trials. They are found to be useful in reducing genital warts. So follow-up, as I told earlier, most cases 9 out of 10, HPV goes away on its own within 2 years without health problems. But when HPV doesn't go away, it can cause health problems from genital warts to cancer. So there were few studies in adults and few studies in children which concluded that there is a need of HPV vaccine in the adolescents. So this background, human papillomavirus infection has contributed to an increased incidence of squamous cell carcinoma of the head and neck, and this study contributes to the etiology of this head and neck tumors. And another study where here the rheumatic diseases, the AIRD they have done. Patients with rheumatological diseases are more prone to infectious diseases, possibly due to both disease-related immune disruption and chronic inflammation, and immunosuppressive agents used in the treatment of rheumatological diseases. In this context, we aim to evaluate the prevalence of high-risk human papillomavirus infection and cervical cytological abnormalities in Turkish female patients with RDs and compare them with healthy controls. 362 sexually active patients with RDs followed up between January 14 to January 21, June 21 were included in this cross-section study. Patients with RDs are classified as autoimmune and non-autoimmune groups according to seropositivity, and data of 883 age-based health controls were used for comparison. So the data was assimilated. The RDs group and health control group are similar in the terms of mean age, BMI and rate of smokers. Cytological evaluation was carried out in 362 patients with RDs, 161 autoimmune and 201 non-autoimmune, and in all 883 health controls. So they have found that HPV test was applied in 286 with RDs and 776. 16 patients with RDs and 58 patients of health controls had cervical cytological abnormality. Of the health controls had high-risk HPV. The prevalence of cervical cytological abnormalities and high-risk HPV infection rate were similar between the patient controls and health controls. So conclusion, it was determined that chronic systemic inflammation, which plays a role in pathogenesis of rheumatological diseases, and immunosuppressive agents used in the treatment did not increase the prevalence of high-risk HPV infection and cervical cytological abnormalities. Another observation studies using traditional factors summarized that the body's ability to clear an infection by the cancer-causing HPV may be largely due to unpredictable division patterns in HPV-infected stem cells rather than the strength of person's immune response as previously thought. So this is another article which depicts that in juvenile autoimmune rheumatic diseases, this article immunogenicity and safety of routine vaccines in children and adolescents with rheumatic diseases on immunosuppressive treatment. This was a systematic review on many of the juvenile autoimmune rheumatic diseases. They mainly dealt with three studies. Grain et al. Here we talk about 42 juvenile JDM, that is dermatomyositis on steroids, drugs immunosuppressants, and healthy controls are 35. They had used Gardasil 1 month, and there was no difference in seroprotection rate in HPV in 16-18 genotypes among health control JDM. After 6 months also, there was no difference in seroprotective rate for difference in treatment and also treatment. That is, though they used immunosuppressants, and seroprotective rate in JDM was 94% at the end of 6 months. So in another study of Hedge et al., Netherlands, 2014, JIA, they studied on JIA, 68 people against 55 health controls. They used Cervarix as a vaccine, and after 1 month there was no difference in geometrical mean titer of the antibodies, and also at 6 months there was no difference. So in each study they studied a different aspect of the vaccine efficacy. One was seroprotective rate, and this study was geometric mean titer of antibodies. And in one JIA did not reach even at the end of 6 months also the seroprotective rate. And another study in Netherlands in 2013, they included many of the JIRDs, JDM, SLE, and 49 health controls. They used Cervarix as 0, 1, and 6 months. They showed that lower GMT among the JRD and 1 JDM after the end of the 3 doses did not seroconvert, and also there was a worsening of the disease activity. So this, the other 3 slides what I am projecting is just a description of each of these studies. So need to develop a vaccine. So they started from 2003. The study was published wherein initial participants who were HPV negative after the end of the 5 years of study, 60% turned to be positive. And in 2006, seeing this study, Merck company introduced Gardasil vaccine protective against 6, 11, 16 and 18 genotypes. And in 2009, GlaxoSmithKline introduced Cervarix, which is against the 16 and 18 genotypes. And both vaccines are found to be protective in 95 to 99%. And in 2006, the federal recommended the age group of 11 to 12 years, the pre-adolescent age group, to be vaccinated. And subsequently in ACIP, the advisory committee also recommended this age group for the vulnerability and recommended the vaccine. And the second dose, 0 and first dose will be within 1 month duration, and the third dose will be in 6 months. The third dose can be shifted to 13 to 26 years. And in 2007, they have found that an observation of 25% of 13 to 17 years women in the US had at least 1 dose because they started the vaccination in 2006. And in 2011, what they found was 53% of females had at least 1 dose, and even the boys started, because of recommendation in the boys, they started giving 11 to 13 years. So these are the committees which are recommending for this HPV vaccine in the adult. And as we see that there are 3 types of vaccines, Gardasil and plain Gardasil, and Cervarix and Gardasil 9. So these are the age groups in which it is given. Pregnancy state vaccination has not proven to be deleterious for fetus, but vaccine can be avoided. And immunocompromised status, we have to give 3 vaccines, 3 doses of this vaccine. The vaccine preparation is from the HPV surface component, and it is found to be not to be effective but to produce immunogenicity. And HPV vaccination, and I already told that it can schedule of vaccination, and effectiveness is being seen both in cervical cancers and also in the oropharyngeal cancers, and even for the partners, even the genital warts has been reduced with the male. And does the HPV vaccine carry any health risks or side effects? Yes. Mild and systemic effects have been seen. Mild common side effects of being pain, induration, soreness, swelling or redness at the injection site, and systemic reactions will be in headache, fatigue, nausea, itchiness, muscular pain and fever. Sometimes dizziness will be there after the injection. We must make the person sit for 15 minutes and then slowly they come out of this acute problem. And the facts, is the HPV vaccine required for school enrollment? Yes, now it is being recommended, and it might differ from state to state based on the age group. Do women who receive the HPV vaccine still need a practice? Yes, because the practice is in vitro or in vivo, they can produce in situ carcinomas other than the HPV virus infection. So we have to do a practice every 3 years from the age of 21. Difficulties in administering HPV vaccine. Yes, there may be some adolescents who are reluctant to receive 3 doses, and some misunderstandings that whether the vaccine will produce some other deleterious effect in the individual, and mother's attitude whether it's compulsory for a school and physician's recommendation is they found that 82% of childhood population in group vaccine with the physician's recommendation. So as physicians, we are bound to recommend this vaccine, and I don't have any disclosures with this aspect.
Thank you, ma'am. Now I think we are running a little short. So, delay is there, so I mean we will take the question answer later, and I will invite now Sarvan Kumar for his talk on avoidable delay in diagnosing septic arthritis, which is a very severe condition in our domain, and what are the controversies regarding it. Dr. Sarvan, please.
The outset, I thank organization for giving me this opportunity. So today I am here to deal with avoidable delay in diagnosing septic arthritis and its devastating sequelae. Controversies will be dealt with consensus by your sir. So as we know, septic arthritis is a medical emergency. There we should not delay in diagnosis because timely intervention preserves the joint. And primarily we diagnose septic arthritis based on the clinical presentation and synovial fluid analysis. And generally it is a straightforward diagnosis if we encounter the classical presentation. But there are a lot of cases in our rheumatology practice which overlaps with rheumatoid crystal arthropathy, which confuses us to reach a diagnosis. So we know the risk factors for septic arthritis include pre-existing joint disease like crystal arthropathy, rheumatoid, lupus, or recent surgery, diabetes, and immunocompromised state, CKD. And but up to 22% of patients with septic arthritis, there are no medical risk factor and no underlying joint disease, and this group will be generally missed by us. And when we encounter any patient with septic arthritis, we have a lot of differentials in our mind, because as a rheumatologist, we see a lot of cases with gout, pseudo-gout, and inflammatory arthritis, and sometimes viral arthritis. And orthopedicians may encounter some tumors or other osteomyelitis, which confuses us to reaching an early diagnosis of septic arthritis. So, if we see any classical case with red hot joint and with fever and chills, it is straight away diagnosis. And the knee is the common site, and if you see any septic knee arthritis, we will straight away diagnosis. But we tend to miss cases where other joints are involved. Like it is generally more common in pediatric group, and other joints like ankle, elbow, which we tend to confuse with inflammatory arthritis. These are seen in almost less than 10% cases of septic arthritis. So, what parameters also delaying for diagnosis? This high grade fever is present only in up to 60% of cases. 40% of cases will encounter with only low grade fever. And chills and rigors, which we classically teach as a sign of infection, is seen in less than 25% of cases. And sometimes joint pain is also blunted in immunocompromised patient. And one more important thing is polyarticular septic arthritis, which is seen in almost 10 to 20% of cases, and this is predominantly noted in patients with gonococcal arthritis and immunosuppressive patients and diabetes and HIV. So other special situations like septic arthritis of cartilaginous joint like pubic symphysis and sternoclavicular joint, which is commonly encountered in patients with IV drug abusers. And for this diagnosis, we generally need CT or MRI, both for diagnosis and assessing the complications. And one more is tubercular arthritis, which follows an indolent course, and sometimes it may take a year to diagnose. And brucella involvement of SA joint confuses with ankylosing spondylitis. So another aspect is concomitant septic and crystal arthritis, though coexistence is very rare. And there were reports that almost less than 5% of samples with septic arthritis are showing crystals. This can be explained by altered pH, synovial fluid pH, because of infection that leads to decreased urate solubility, and also shedding of crystals by infected synovium will also lead to presence of crystals in the septic joint. So, presence of crystals in synovial fluid is not sufficient to rule out bacterial invasion. So, I want to make a statement that all patients with apparent gout joint or crystal arthropathy should also undergo gram staining and culture to exclude concomitant septic arthritis. Coming to the lab diagnosis, gram stain and culture we do for diagnosing septic arthritis, but high variability and sensitivity issues will delay the diagnosis, and also overlapping features with the crystal arthropathy and rheumatoid confuses us to reach the diagnosis. And blood cultures is positive in almost 9 to 36% of cases of septic arthritis, and sometimes it is the only test which gives us clue to diagnose septic arthritis. The synovial WBC, fluid WBC count, if it is greater than 50,000, we take it as cutoff for septic arthritis. But the main problem is even crystal arthropathy cases, we can see synovial fluid count, WBC count of greater than 50,000. And almost some patients we encounter with low WBC count, and in one study they quoted up to 1/3 patient they have synovial fluid WBC less than 50,000. These are generally encountered in patients with disseminated gonococcal disease or leukopenia or immunocompromised patient. And even in joint replacement, even the cells of 1100 we should consider it as septic arthritis. And gram stain, which we commonly do in our practice to diagnose for septic arthritis, it has very low sensitivity of around 29 to 52%. Gram-2 cases have little more higher sensitivity, 71%. And synovial fluid culture is positive only in 40 to 70% of cases, and generally we get the report after 72 hours, so that is a time consuming procedure. And when we think of culturing, so what is the ideal media, whether it is solid media, blood culture, body, they say that solid media will miss almost 20% of cases of septic arthritis, and if we inoculate these blood into the blood culture bottles, where they will show higher end of pathogens and fewer contaminants. And negative culture on the synovial fluid can be explained by giving antibiotics prior to synovial fluid analysis, and sometimes small number of bacteria with the brisk neutrophilic phagocytosis will show negative culture, and inadequately sample was plated, or if we are encountering any pathogens which has fastidious growth requirements. And serum inflammatory markers, leukocytosis is seen in only 50 to 60% of cases. Though ESR and CRP has very high sensitivity, it has poor specificity to identify septic arthritis, because these can be elevated even in patients with inflammatory arthritis and crystal arthropathies. And there was a study in pediatric group where they said CRP of more than 20 we can straight away consider septic arthritis, because high CRP indicates more of infection related. And to conclude on this, we can say these are better negative predictors. If they are low, we can rule out septic arthritis than a positive predictor. And the synovial glucose and protein have failed to show any diagnostic utility. And there are recent analysis studying on various biomarkers like delta neutrophil index, calprotectin levels, and lot of things are going on, which I will be delving in the next slide. And CD64, they identified it as one of the good marker in distinguishing septic arthritis with area under curve of 0.8, and even synovial TNF was studied and which has showed sensitivity of 95% in diagnosing septic arthritis. And serum procalcitonin, which we commonly do in sepsis patients, but even in septic arthritis group, the serum procalcitonin was higher. With cutoff of 0.5, the sensitivity was around 59% and specificity of 86%. And one group has studied even synovial procalcitonin, which was higher in septic arthritis when compared to inflammatory arthritis group. But the sensitivity here it is very low, but specificity is very high, 96%. So procalcitonin may add to a diagnostic accuracy in finding out septic arthritis, but synovial procalcitonin has less sensitivity. And one more common thing we can do in our practice, which I learned after studying for this preparation, is leukocyte esterase and glucose levels that we can do with a urine dipstick, which is available in our clinics. So we can dip this urine dipstick in the synovial fluid for 6 minutes, and we can see the result. Where because of the bacteria, the leukocyte esterase is produced by the activated neutrophils, and this bacteria utilizes the glucose. So we found low glucose in the synovial fluid. So when we do analysis. When they have done analysis by seeing these factors alone, the leukocyte esterase 2+ and 3+, and glucose strip negative, they did not find much possible evidence to support. But when they combine these two parameters, that leukocyte esterase and low glucose, they found that it is very best marker to discriminate the septic arthritis with a sensitivity of 85% and specificity of 100%. So it is a cheaper tool which can be used, but large data is needed to establish this one. And another is lactate levels, which is high in any which is high in septic arthritis because it is produced from the bacterial metabolism. So lactate, when compared to the crystal arthritis and non-inflammatory thing, lactate will be high and glucose will be low. So this synovial lactate by glucose ratio is also relevant in discriminating septic arthritis with area under curve of 0.85 with sensitivity of 52%. And it is important that we should measure D-lactate, which is produced by bacteria, and rather than L-lactate, and I think most of the lab will not have this differentiation. And there was a recent study where a group analyzed almost 26 different diagnostic tests across 15 papers to reach a conclusion of early diagnosis of septic arthritis. And in this one, as we said, there are markers like lactate by glucose ratio, high likelihood ratio of septic arthritis diagnosis, and calprotectin, if it is greater than 150, it indicates septic arthritis, and if it is less than 52, we can take it as negative predictor for septic arthritis. And synovial fluid greater than leukocyte greater than 50,000 with neutrophils 90% are better sensitivity and specificity. And this leukocytes greater than 50,000 plus negative crystals also increases the likelihood ratio of septic arthritis. And as we discussed, the leukocyte esterase 2+ or 3+, and low glucose also is a better predictor for septic arthritis. And this is one study where they studied almost all inflammatory markers like WBC greater than 50,000 and CRP greater than 80, high ESR, TNF, that is synovial fluid TNF greater than 10, and serum procalcitonin, synovial fluid procalcitonin, they were discriminating septic versus non-septic inflammatory arthritis. But IL-6 was more or less similar in both groups, which is not able to discriminate septic arthritis. So after this study, they concluded that almost 3 diagnostic tests have reached greater than 80% sensitivity and specificity that include synovial fluid leukocyte count greater than 50,000 and neutrophils greater than 90%, and other thing which I explained, leukocyte esterase, which we measure on the urine tube. And so they proposed a flow chart. So if you encounter any tender and swollen joint, if the cell count is greater than 1 lakh, you can straight away diagnose it as septic arthritis. If it is 50,000 to 1 lakh, then you have to consider additional tests, either synovial lactate by glucose ratio or calprotectin or neutrophils greater than 95% or leukocyte esterase. If any one of these is positive, you can consider it as septic arthritis. And whenever you encounter cell count of less than 50,000, and if you have synovial fluid TNF less than 10 or procalcitonin less than 0.5 or synovial calprotectin is less than 52 and neutrophil count less than 15, we can rule out septic arthritis. And another is preception, which they studied to differentiate between crystal arthritis and septic arthritis, where they found that synovial fluid preception is much elevated in septic arthritis. Even in the blood, preception is also elevated. And the area under curve for synovial fluid preception was 0.93 with sensitivity of 85. So preception is a marker which can be used in differentiating septic arthritis versus crystal arthritis. So there was another study where as a clinician we tend to avoid lavage and we delay the lavage. So there was a study where they studied the duration of time of onset of lavage was calculated at T1 group, they less than 6 hours. Then lavage done in 6 to 12 hours is T2 group, and lavage done in 12 to 24 hours is T3 group, and greater than 24 hours is T4 group. So in this study, there was no statistical difference even if we delay the lavage in both mortality or ICU admission, and they stated that almost 48 hours delay in arthroscopic lavage will not increase the risk of mortality. So understanding this, we know the devastating complication if we don't treat, like the patient may suffer osteomyelitis, mortality, secondary sepsis, and secondary osteoarthritis, avian, osteonecrosis, muscle atrophy, and these are all complications if we delay the diagnosis of septic arthritis. And there was a multiple tools are available over the net to identify septic arthritis. This is one of them, is multivariable assessment tool, where they identified by conducting the univariate analysis, and they identified some predictors, and by doing multivariate regression analysis, they formulated a calculator that these are the pre-aspirate factors which we have to consider, and if there is positive we have to take it, and this is a computer based tool, and this is the after synovial fluid analysis, these markers has to be taken, and by complex mathematical calculation which the computer will do, we can get a score like less than 10% risk, which indicates low risk group, and moderate risk is 10 to 50%, and high risk group means that it predicts high risk of septic arthritis if you get a score of greater than 50. So concluding my session, currently synovial WBC and the percentage of neutrophil is the most reliable diagnostic test which can be get rapidly to identify septic arthritis. And heterogeneity of these diagnostic tests and varying population cells included in the study makes it difficult to create generalizable uniform conclusions. And biomarkers should always be evaluated in context of careful clinical and microbiological assessments. Thank you.
Thank you. Thank you. Now I invite Dr. URK for his comments on septic arthritis.
Good morning. Dr. Shravan has dealt very well about the problems of delay and how we can probably diagnose the septic arthritis. If it is straightforward, the diagnosis would be easy. So now we realize how difficult it is sometimes. The general principles are the septic arthritis is a diagnostic emergency due to the morbidity and mortality and the functional risk related to structural damage. It must be managed by a team, actually it's a team effort. orthopedic surgeon, medical, there is rheumatologist, microbiologist, paramedical. So these are the ones which we have taken French recommendations, joint and bone spine, 2020. The recommendations are septic arthritis should be considered in all cases of acute monoarthritis, whether the patient is febrile or not. And the number of joints do not rule out the diagnosis. Suspected septic arthritis justifies looking for signs of immediate severity or systemic inflammatory syndrome. It's essential to perform joint aspiration before administering antibiotics. Most of the times in the emergency we may have to give antibiotics, but draw the fluid sent to the relevant investigations for a cytobacteriological analysis especially. The additional inoculation of the synovial fluid in blood culture bottles is recommended. This is the one which actually he has highlighted very well. In particularly the case where prior antibiotic therapy or long waiting time, the patient could have taken antibiotic before he comes to the rheumatologist or orthopedic surgeon. The synovial fluid microcrystal detection must be carried out in addition to the cytobacteriological analysis. This is an important finding which he has again mentioned, Dr. Savan. The presence of crystals does not include the gout. So gout, sepsis, these are the ones which we come across in the differential. But the presence of the crystals does not rule out the sepsis, underlying sepsis. At least 2 sets of blood cultures should be performed, even in the absence of fever. Probabilistic antibiotic therapy can also be considered if there is a clear purulent synovial fluid without crystals. Go ahead with the antibiotics after drawing the fluid and sending for the bacteriological investigations. The total duration of the antibiotic therapy, IV initially, then oral, should be 4 to 6 weeks of bacterial septic arthritis. In fact, we have a chapter for the postgraduates and general practitioners. Dr. Aman Sharma and Rohini Handa brought out urgencies and emergencies in rheumatology. There is a book which must be available, and the septic arthritis is given by us with the chapter. To conclude, early diagnosis and treatment are important to improve the treatment outcomes for patients with septic arthritis. However, highly sensitive and specific rapid tests for early diagnosis of septic arthritis are evolving. The latest recommendations, the latest evaluation, well done by Dr. Savan, have been highlighted now in front of you. The rare entity with heterogeneous presentation and in fact emergency presentation makes it difficult for prospective studies. We cannot have actually prospective studies. It doesn't rule out that we should have actually in Indian studies we should be having. So after listening to him and the latest insights, I think we may be missing some of the patients with the septic arthritis. And if you miss them, there may be ankylosis, the damage, and even so a lot of morbidity and even mortality. So I think I'll conclude here the consensus. Thank you very much.
Thank you, sir. Thank you for nice conclusions. Now, should we invite for question answers?
Though the time is up, I think no lectures will not be complete unless we have some question and answers, please. So from the audience, you can direct question to any one of the speakers. Yes, please. Identify yourself and...
Hello, I'm Dr. Akansha Kapoor from New Delhi. My question is pertaining to COVID and the development of autoimmune diseases afterwards. So, I just wanted to clarify the time duration, is there any consensus in this regard? How long should we, what should be the time duration between COVID-19 and the autoimmune disease, and when can we attribute the autoimmune disease to COVID-19 infection or vaccination? Is there any consensus regarding this time duration?
Pooja, afterwards Lundenberg. Shall I go ahead?
So there is no clear time gap. We have a paper from Lancet this month only that also specifies that there is no clear time gap between this. But like for any of these kind of manifestations, before attributing it to COVID, we should rule out whether it's de novo. Because even before COVID was there was a baseline prevalence of all these autoimmune and rheumatic diseases. So with this, the new virus circulating, the baseline prevalence has not gone away. So all the three possibilities can be there. It could be COVID related, it could be triggered by COVID, or both of things have come together. So if you have excluded everything, only then attribute it to COVID. And the only way to prove it, to take it to lab and do in vivo and in vitro studies in mice models, and then to replicate it, and only then you can prove it, the causal association. Otherwise, difficult.
Any comments from Dr. Lundberg?
Yeah, I agree, and we should remember that many of the autoimmune diseases that we work with have probably started maybe 10 years back with the appearance of the immune reaction. So it's hard to say when they actually start. So I think that they could be triggered by an infection, but or several infections. So it's very difficult to say.
Thank you, sir. An additional add-on to that, is it important to know whether it was COVID triggered? I mean, does that make a difference to the prognosis? Like we discussed, the prognosis is better because they are usually self-resolving. So is this even an important question to ask whether it was COVID-19 induced or not?
So regardless of the COVID-19 related to the autoimmune disease, I think the treatment prognosis are the same as autoimmune disease. Do you agree with that, Pooja? Yeah.
Thank you. Thank you.
Any more questions before we conclude? Dr. Lundberg?
Not a question, but a comment. I think we need to follow these patients, and if you have registers, to follow the patients in registers, and then we may see, we can learn from that.
After a large cohort, actually, yes. Yeah, please.
This is to the last presenter, Dr. Shravan, I think. Whether the profile of microbiological etiology of septic arthritis has changed in the recent years. I mean to say what, because is where I practice it in Pondicherry, we get pretty many cases of myelioidosis. So generally when we see septic arthritis there, we generally tend to give ceftazidime empirical therapy rather than others. So I would like to know your experience.
The commonest organism and the antibiotic you choose.
Yes, as far as Indian data is not available, but Western literature, everything it says Staphylococcus is the most common, followed by Streptococcus, followed by gram-negative bacteria. But this has not been much changed over the years in adults. But in pediatric patient, previously we used to see Haemophilus influenza as a common thing. But due to vaccination and preventive measures, and again the Staphylococcus has become. So it is the same old antibiotic policy which is recommended, except for children the organism has not much changed. In myelioidosis, even it is reported very rare. In
Thank you. You will conclude? Yeah. We shall conclude here and then invite the organizing member to take over, please.
Thank you.
Thank you very much.
Great, thank you, sir.
Thank you. Sit beside you. Thank you. Well, good.
Good morning. Good morning. Good morning. Now we shall start with next session, which will be gout advances. Gout distinguishes itself in the history of Homo sapiens since the time immemorial. It was first identified by Egyptian in 1640 BC. It is one of the most understood and well described arthritis, but being well neglected by the patient itself. Out of curiosity, I would like to show one slide from one of my patients. I'm from Arunachal, where our customs and tradition is alcohol and meat consumption. So this is one of my patients who came with polyarthritis with this kind of presentation, with so much of destruction and topicious gout. So here you can see the x-rays, multiple destructions, ulcerated with chalky materials, and this is the presentation which I got from Arunachal. So to chair this session, with due honor and respect, I would like to invite our chairperson, Sir Dr. Jose Paulo P. Lorenzo from Philippines. Thank you, sir. And Dr. Molly Taba from Puducherry. Ma'am, please.
Hello, good
Thank
morning.
you.
Thank you.
So, good morning, everyone. Our first speaker is he around to give a talk on update on gout guidelines. Dr. Sami Salman. I saw him in the next hall, so I know he's physically present in the building.
Yes. Can we call Professor Sami Salman, please? Or sir is on the way, yes. Oh, no, that's Professor Terran Gibson.
This is Professor Gibson. Yeah, welcome, Professor. We're missing Professor Salman, Sami Salman. So would you be ready to give your talk?
I noticed that most people are heading downstairs for coffee.
For coffee.
Yeah, I went down for quick once. I was on the building overwhelmed by the crowd being downstairs. So the audience is downstairs.
Okay.
Is it worth waiting?
2 minutes maybe? Yes, we can.
And hopefully Professor Salman will be on his way back from the coffee break.
Oh yeah, we were supposed to begin at 10:15. That's the reason.
This is now.
We are like
We're 5 minutes.
5 minutes
late.
late. Yes.
Oh, there he is.
He has arrived right on.
This is Professor Sami Salman.
You can keep your coffee here, sir. There's place.
So Professor Sami Salman, Professor Emeritus from the College of Medicine, University of Baghdad. You have the floor, sir.
Thank you. Actually, I'm delighted and honored to be among you. It's one of the best conferences that I attend year round, and my love to this country is beyond any description. So actually, this is an Amman Star, and the person next to me is Justin Mason. And Justin Mason, we visited the temple there, and a few months ago, I needed him to send me an article. So I wrote to him, please Justin, can you send me this particular article? I can't get hold of it. Then I received a letter from his secretary saying, sorry to tell you, he passed away.
Oh.
So Justin Mason was one of the people who were fond of this country, and he visited India so many times. He is a great vasculitis person, and I'm sure Aman Sharma was really, very sad for his passing. And this picture, this photo is, you can see the first person is the chairman, so that's Paolo Lorenzo, and the third person is Sayyid Atiq al-Haq, and myself. We are having a nice coconut water in Bangladesh, and it just happens by accident that all the three of us are part of the steering committee for putting the guidelines for gout. That was published in the International Journal of Rheumatology. So the steering committee was sort of a hierarchy of sort of technical staff who really were searching all the papers worldwide, and the other part were studying the evidences and putting the recommendations. So that for the asymptomatic hyperuricemia, which people keep asking us, is that among patients with asymptomatic hyperuricemia and hypertension, we recommend against urate lowering therapy in patients to reduce the risk of major cardiovascular events or mortality, because of the 10 randomized controlled studies, there was inconclusive evidence that urate lowering therapy makes any difference to MACE. And again, I mean, for chronic kidney disease with asymptomatic hyperuricemia, again, the same recommendation is valid, that it was against using urate lowering therapy. So for treatment of acute gout, and the recommendation was the same usual thing that we have been taught in medical schools, that colchicine is the #1 drug to be used there. Non-steroidal comes next, and sometimes systemic corticosteroids. All three probably are first line. And in acute gout, the recommendation here is that we should use the low dose colchicine, probably 1.5 to 1.8 milligrams per day. So that comes in countries who had the dose of 0.6 3 times daily, and in my country where it is 0.5 milligram 3 times daily, against the previous recommendations where they keep loading the person with the colchicine until he gets diarrhea and until he gets side effects. This is no more valid. And again, in acute gout arthritis, there is not sufficient evidence to inject the joint. I mean, no randomized controlled trials were available to be studied. And the publications about this was really very low quality publications with no randomization. Again, in acute gout and the treatment of urate lowering therapy naive patients with gout, there is again insufficient evidence to recommend initiating the urate lowering therapy, i.e. whether you are using allopurinol or you are a fan of febuxostat during the acute gout flare over after the flare. You know the previous recommendations, they say wait until the flare subsides completely and then you start with the allopurinol or with febuxostat. Actually, the studies, there are 6 randomized controlled trials, did not show conclusive evidence for increased gout recurrence or for pain when you start during the attack. So you can actually, don't need to wait. I mean, once you are sure this is an acute attack of gout, you can actually give the patient the urate lowering, whichever you favor, whether it is allopurinol or febuxostat. Prophylaxis against flare when initiating urate lowering therapy. And again, this is the same recommendation that has been held before, is that you should start a patient with colchicine and he should stay on it for 3 to 6 months at least. Again, this is one measure that you are doing to prevent an acute exacerbation, because previous so many studies have proved that you need a prophylactic colchicine while you are starting the patient on urate lowering therapy. Again, low dose. You don't need a high dose, and probably colchicine of 0.6 milligram per day or 0.5 milligrams TID for 6 months. Then you can stop the colchicine and continue with the urate lowering therapy. However, some people are intolerant to colchicine, or there are some contraindication to it, and then NSAID can be used, and again for the same duration of that we mentioned, 3 to 6 months. Of course, some people would feel a bit worried about keeping a patient on NSAID for 6 months just because you have put him on urate lowering therapy. But this sort of probably protects him from getting an acute attack while he is loading with the urate lowering therapy. And there was some question, what happens if we cannot give colchicine and we cannot give NSAIDs? Shall we give steroids? And the recommendation is that there is insufficient evidence to recommend for or against the use of systemic corticosteroids as a prophylaxis. So for this, we cannot really give an answer. We wait probably for more papers, good papers, to tell us if we need to put the patient on steroid during these months. Urate lowering therapies, I remember one of my students saying to me, I was going to put a patient personally, going to put him on allopurinol, and he said, Prof, why didn't you send him for HLA-B5801? I said, what? And he said, you need to do this test for the patient before starting allopurinol. I said, I never heard of it. And then I checked that there is a very small population, mainly in Southeast Asia, that small population that have got this gene, and that these people are prone to develop serious, severe cutaneous adverse reactions if they take allopurinol. But for the rest of our countries, and even in India and in my country, we don't have this population. And so probably those countries where there is this allele, then yes, it is worth testing. And it's not available even in my country, this testing, and we never really needed it. And I'm repeating that among gout population with high prevalence of HLA-B5801, the recommendation is that we neither recommend for or against febuxostat over allopurinol. The reason is that the first reports, they were mainly concentrating on allopurinol, that it is causing the severe skin reactions. However, there are some other papers that were mentioning that it's not that high, and it's not, and that we can use either of. Again, urate lowering therapy. When do we start it? When should we start it in a gout patient? And the newly diagnosed gout patients, the number that we actually put is 9 milligrams per deciliter, that it is worth putting the patient. You are giving him something lifelong. It's not like the practice that some of our colleagues do. They put the patient for only few months or only few weeks even. I mean, you are going to sentence him for life. So probably it's worth when his serum uric acid is 9 and above. Less than that, there is the evidence that probably you don't need actually. Of course, other considerations for recommendations from other guidelines. Cost is also important. for maintaining urate lowering therapy, except for a lower serum uric acid. Many people cannot, they pay from their own pocket, and this might really very costly to them. Chronic tophaceous gout, and among patients with chronic tophaceous gout, we recommend the use of xanthine oxidase inhibitor, whether allopurinol or febuxostat, over non-urate lowering to achieve resolution of tophi. So they should be used for chronic tophaceous gout. And among the chronic tophaceous gout, patients with serum uric acid above 6 milligrams, we suggested against using lesinuride to xanthine oxidase inhibitor for resolution of the tophi. Complicated gout and non-responders, and among adults with refractory gout. And these refractory gout are those who continue to have a high serum uric acid despite treatment. And there is insufficient evidence to recommend a uricose uric agent and xanthine oxidase inhibitor in combination, other than the one that is studied well, which is lesinuride allopurinol combination, to achieve target serum uric acid levels and to reduce the gout flares. So this combination has got 3 randomized controlled trials for the effectiveness of the combination of lesinuride and allopurinol. And among adults with refractory gout who have contraindication to xanthine oxidase, we suggest pegloticase if available, because many of these countries, including mine, they don't have pegloticase to achieve a target serum uric acid. And in moderate to severe renal impairment, and these patients with gout and renal impairment, there is insufficient evidence to recommend for or against the use of urate lowering therapy to prevent chronic kidney disease progression. And it showed that whether you give them urate lowering or not, it ends up the same, I mean, in terms of prognosis. The non-pharma, and I'll go quickly, limiting alcohol intake, limiting purine-rich. This is, I mean, almost like our bread and butter recommendation that they should try not to limit both alcohol and purine-rich diet. And weight reduction is very important. And some patients, I mean, acupuncture may be an option if they continue to have pain. And there are some 7 studies of the use of acupuncture for the pain mainly. And there are some studies on herbal medicines. We couldn't make any recommendation. There was very low confidence of evidence, and there is one pian. Most of them have Chinese name, yellow dragon, a wonderful seed, formula, compound, toppling. There are studies on them, but we could not really make sure whether we can recommend them or not, so there was no recommendation. So thank you for listening.
Thank you, Professor Sami Salman. We request you to join us here. Meanwhile, the next speaker would be Professor Terence Gibson. Sir will be speaking on acute challenges of geriatric rheumatology, that is gout and beyond. Over to you, sir, to start the talk.
Thank you very much.
Thank you, sir. Thank you very much.
At present, a huge amount of speculation about how hyperuricemia and gout can affect other organs, and much of it is based on rather weak evidence. And so I've decided to stick to what we know, raising some questions about what we don't know, and make some allusions to some of the rather wilder theories about how hyperuricemia can affect other organs as we go along. So I'm going to go back to basics. So this is a back to the future talk, if you like. So I'm going to touch on biochemistry, physiology, pathology, and pharmacology. Actually, pharmacology I'll leave out because you've just had enough of that from my esteemed colleague here. But knowing about the basis of gout has helped us to develop the treatments. It's worth noting that this is a disease that's on the increase throughout the world as people become more prosperous. And despite its ancient history, it continues to attract interest. And even in last week's New England Journal of Medicine, a whole article devoted to the subject from A to Z. I'm going to talk a little bit about the formation of urate crystals because that's where we started. Urate crystals are what we deal with mainly in clinical practice. There are things we do know and there are things we don't know about the way the crystals form and where they form. First of all, a little basic biochemistry, which is recently fed into the theories. For example, we know that xanthine oxidase is an important part of this process of eliminating purine waste products. And xanthine oxidase can cause the development of reactive oxygen species, and some would claim that this is the reason why you have damage to the kidneys, possibly the heart, and other tissues. But the evidence is so weak. But even xanthine oxidase has been dragged into this discussion about how uric acid alone can be a cause of inflammation and damage organs outside the joint. So there's no doubt at all in anyone's mind that gout is caused by the crystals of monosodium urate. And they're liberated into the joint for one reason or another. So MSU, monosodium urate, is an interesting product of purine degradation. It exists side by side with disodium urate, but which tends to be innocent because it is much more soluble. Uric acid then is the end product of purine degradation, and most of it is endogenous, and we derive a small amount from our diet, and it's a feature of metabolism in primate birds and even some reptiles. Just a little bit basic biochemistry. Uric acid, then you see its formula here, it's a weak acid. Monosodium urate displaces one of the hydrogen ions with sodium, and disodium, two sodiums for two hydrogen atoms. In the blood, uric acid circulates as monosodium urate, and in the urine as uric acid. Important to note that MSU is much less soluble than disodium and uric acid, and it tends to be influenced by temperature more than any changes in body pH. And that may explain partially the fact that you see tophi in the extremities, end of your fingers, over the pinny, on your toes, in your cold of extremities. Maybe. Just switching to some basic physiology then. So most patients who have a history of gout have a relative low renal uric acid clearance. And this has generated a lot of interest about the causation of hyperuricemia itself. I've had the opportunity to live in New Zealand and study the Maori people there who have an exceptionally high level of gout and hyperuricemia. And one of the critical studies that I did while I was living there was to look at their urate clearance, and it's exceptionally low compared with the European population who live in New Zealand. And that's interesting. It raises questions about the handling of uric acid by the kidneys. And this is a patient from that Maori population who has chronic tophaceous gout. And we've got to know a lot about the way the kidneys excrete uric acid. And it's highly dependent upon a flow one way and another in the proximal renal tubules. And that flow is dependent upon renal urate transporters, of which there are several. And each of these can be identified with specific genes. And so it was thought that maybe those under-excretors who constitute the majority of people with gout, and especially looking at the Polynesian population, we will find evidence that genetic variations account for the impaired urate clearance. But we haven't discovered that, you know. We're using genome-wide searches. There have been lots and lots of mutations within the gouty population of a number of the genes known to be related to urate transporters, but no consistency. And some of those mutations associated with hypouricemia or hyperuricemia. But in the Polynesian population, for example, where it was hoped that we would find a specific gene or gene mutation to account for this amazing predisposition to hyperuricemia, it simply hasn't occurred. So it's probably multifactorial. So there clearly is a lot more exploration to be done here. In general, URAT1, which is one of several urate transporters, is considered to be the most important. But again, in isolation, it doesn't explain the low urate clearance that we see in so many patients with gout and in this Polynesian population. So in this series of 69 patients with primary gout, it was possible to demonstrate 6 different mutations, you know, in 23% of people. No consistency. But the same mutations were also seen in people who didn't have gout. And so this is almost like a dead end. Just say a little bit more about the kidneys in relation to young people with gout. Very important to consider uromodulin-associated kidney disease when children or adolescents present with gout. So this is a clearly genetic abnormality that is associated with kidney failure. Most of these patients end up having renal transplants at a young age. And the other reason where you might encounter gout in young people, of course, is HPRT1 enzyme deficiency. Right at the beginning, one of my slides showed you the importance of the HPRT enzyme in the process of recirculating uric acid. So if it's missing, that process, the so-called salvage pathway, doesn't occur. So you have a build-up uric acid, it's not recirculated, as it were, back into the purine pathway, and you get gout and kidney failure. And when it's completely absent, the Lesch-Nyhan syndrome, which is associated with neurological abnormalities, which raises other questions about the link between uric acid, urate, and the nervous system, but you can leave that apart. Neurological symptoms and sadly early death in these children. A little bit about urate crystals then, just turning back to the crystal itself. It's, I've tried to configure it here. You've got uric acid, urate linked with a molecule of sodium and water. And it forms this sort of lattice. And the formation of crystals is, as is obvious, highly dependent upon the concentration of the monosodium urate in the circulation. But crystal formation and the urate have a predisposition to collect on areas of collagen. They have this affinity for each other. And in laboratory studies, it's been shown that you're going to get crystallization if you expose high concentrations of monosodium urate to cartilage derivatives containing collagen. And interestingly, when you put monosodium urate into synovial fluid from gout patients, crystal formation, again, is more likely. So we think that this affinity for crystallization in collagen accounts for the distribution that we see in patients with gout. And where cartilage is already damaged and exposing the underlying collagen, you're more likely to have accretions of crystals. And the process is one of primary nucleation on the cartilage, and then on top of the initial layer of crystals, more crystals develop because they have a similar structure. I've used some of the crystal terminology there, but I don't want to even try and explain what these mean. I'm just showing you now how collagen is arranged in cartilage, and these sort of wonderful parallel bundles. And when you stain cartilage for uric acid, you see the same sort of pattern. So what I'm showing you here is how urate, monosodium urate, crystallizes out in collagen in cartilage and is aligned precisely with those lovely bundles of collagen that I illustrated a moment ago. So when a joint is damaged, as you see on the right-hand side here, exposing the underlying cartilage and thereby the collagen, you're more likely to have crystals developing, which may well explain, and probably does explain, some of the distribution of tophi. So this is what happens when you have a lot of, when you have hyperuricemia and crystals begin to develop. They lie on the joint surface, as you can see through the arthroscope on the right. On the left, you've got electron microscopy of layers of monosodium urate just lying there benignly on the cartilage. And this is almost certainly the process which has taken place in this patient here who's got a tophus overlying a Heberden's node. So where there's a damaged joint at an Heberden's node, then crystal formation is started and developed until you get this tophus. So in brief, I've spoken about reduced solubility, aggregation of monosodium urate, nucleation, and then crystal growth. And here we are, the agents of destruction, sodium urate crystals themselves. So we know then when these are liberated into the joint cavity for one reason or another, like a falling urate which upsets the homeostasis, or trauma, then the crystals are ingested by synovial macrophages, and there's an influx of leukocytes which continue ingesting the crystals, and they stimulate that inflammasome cascade, which generates very, very severe inflammation. The sort of inflammation, and the same sequence that you see in familial Mediterranean fever and adult onset stills and a number of other diseases. Ever so briefly now, this is where much of the interest lies, and what I suspected the organizers wanted me to talk about, but huge amounts of this is speculative. We know for sure that hyperuricemia and gout tend to be the associates of plenty, to quote, in other words, a healthy but overindulgent diet. Obesity, there's no doubt there's a relationship with the level of your urate, and that probably operates through the insulin effect. As you increase your body fat, your insulin level rises, and insulin will, to an extent, impair urate clearance. Then the association with hypertension. Now, just emphasize that these are associations, and cause and effects remain to be established. And there are many people, as I alluded to a little earlier, who are trying to turn what we know about uric acid and monosodium urate into explanations for why we have these associations, but they're actually probably multifactorial. I don't want to refer to any of the studies that I've done decades ago, which point straight to the fact that the way we live is probably more important. My last slide dealt with the treatment of that, but just continuing down this list of things, chronic kidney disease, alcoholic stress, which used to be thought reduced urate clearance, but studies which I did myself many years ago showed it actually stimulates purine production and overproduction of uric acid. We all know that diuretics with the exception of spironolactone, probably compare renal tubular secretion because they compete with binding sites with those urate, tubular renal urate clearance sites. And then the question of hypertriglyceridemia. Hypertriglyceridemia has an interesting history in relation to coronary artery disease. That's, in the gouty context, it's certainly related strongly to alcohol and to obesity. Whether other factors involved remain unknown, but probably not. Whether that accounts for the weak association with coronary artery disease remains to be seen. There are some who believe, I've mentioned the crystal formation because that argument too has been taken to the coronary arteries, and there's no doubt that some studies have shown that crystals can be found in the coronary arteries. As I said, they have an affinity for collagen, and collagen lies within the vessels. And in fact, dual energy CT studies have shown that urate crystals can be found in many, many sites, but it's completely unknown whether they are in any way associated with inflammation or diseases in the organs where they're found. So I've covered as much ground as I can. As I said, my last slide was to do with treatments, but you've already heard how gout should now be handled, and so I'm going to stop there and answer any questions you might have. Thank you very much.
Thank you, Professor Gibson. If you would kindly join us in the front. So I'm going to open the floor. We have a few minutes for questions. Yes, we have a question from Dr. YK.
Yeah, mic test, Professor Salman. Nice to meet you finally. We see each other on Zoom, but now I see you in person. So it's not a question, but just a clarification that the HLA 5801 not only affects a few countries in Southeast Asia. The HLA 5801 was discovered by a Taiwanese dermatology in the Han Chinese. So the Han Chinese is about maybe if you look at in China alone, is more than 1 billion people having the genes. So it's not a few countries, and if you look at the Chinese diaspora, it'll probably be a lot of people with the it's about 20% prevalence of the HLA 5801, but the positive predictive value of hypersensitivity is, even if you have that gene, is about 2 to 3%. So just a little clarification. Thank you.
Thank you for the clarification. That's wonderful.
Any more comments, questions? Yes, sir.
I am Dr. Paramjit Singh from Uttarakhand.
Sound. Yeah.
I am Dr. Paramjit Singh from Uttarakhand. I wanted to ask, in the urate lowering therapy, which agent do you prefer, like allopurinol or tabestrostat? You have given the recommendations, like any of them can be preferred. Do you have any cardiovascular risk factors also associated with tabestrostat?
It's a very nice question, actually. Thank you. To be honest, I mean, during our guidelines, we did not find a preference. I mean, previously there was sort of more promoted febuxostat for people with CKD, but then there was some sort of warning now about febuxostat in terms of cardiovascular probably events. So altogether, personally, I would leave it to the treating doctor to decide, but I wouldn't put any weight for one of them against the other. Personally, I still use the allopurinol, which I'm used to use, and I'm confident in it.
Thank you, sir.
Thank you.
Yes, Dr. Ravichandran.
Yes, I'm Dr. Ravichandran from Chennai. What is the maximum recommended dose for febuxostat? That is question number one. is there any drug that reduces the tophus formation once they are formed? Is there any drug that reduces the tophi?
Yes, thank you. May I mean, really beg you to go to our recommendations. You will find the answer there is very clear how to deal with tophaceous gout. I had to go quickly because I had 30 slides. But again, the allopurinol, the urate lowering therapy, is good. And it does definitely reduce the size of tophi, and even some tophi disappear. Febuxostat itself is good, and again, it causes a reduction of both the size and the number of tophi. What else did I want to? Oh, the maximum dose. At least in the references that we went through and the publications, they mentioned 120 milligrams of daily of febuxostat. The papers did not mention any higher dose. I don't know if this is for you. It's okay. Yeah. Thank you.
I think we one more question. We have time for one last question.
I would like to ask one question to Professor Terence Gibson. Sir, you had mentioned about GWAS studies in gout. Whether any specific data is there on doing GWAS in young onset gout, sir?
Well, I've drawn attention to the only genetic related illnesses that we do I didn't recognize, but there may be others. And yes, perhaps that has already been done, but I'm not aware.
Yes, sir.
May I make a short comment for our students or postgrad students, and that tophus in Latin means chalk stone, chalk. And during the Victorian ages, the British, the grandparents of Alan Dixon, of Terry, they all had very good food, and they all drank a lot of whiskey because it was an empire where the sun never sets, and so they were rich. And when they play their favorite game, which is snooker, and they don't find a chalk, they all use the tophi that they have in their fingers. So how much the scoring? 1, and he scores with the tophus in his fingers. So his chalk is from his own person. Just for a joke. Thank you.
Well, thank you, Professor Salman, for that little anecdote.
Okay.
So I think we end this part of the session, and I'd like to thank Professor Sami Salman and Professor Terence James Gibson for spending a few minutes with us to talk on the topic of gout.
Thank you.
Thank you very much, sirs. We go now to brainstorming.
Yes.
Okay, so
She will be speaking.
so we'll now we can ask Dr. Kriti Kishore to come up. You have the floor.
Kirti will be speaking on young onset versus geriatric onset gout in Asians. The question is whether both diseases are on the same side of autoinflammation. You may begin, Kirti.
Good morning, everyone. So today I'll be speaking on young onset versus geriatric onset gout amongst Asians. And so what are the important questions that need to be addressed as far as young onset and geriatric onset gout is concerned? So are young people with gout more likely to be overproducers as compared to underexcretors? Do genetic polymorphisms affect urate levels in young? Whether there is a difference in clinical presentation in both these scenarios? Whether there is a difference in serum urate levels between the young and geriatric onset gout? Does early onset gout increase risk for metabolic syndrome? Does early onset gout increase the risk for tophi formation? And whether the renal function in older people determine the serum urate levels, and what is the role of various comorbidities in determining serum urate and its risk for progression. So before we move on to the pathogenesis, this is a graph from a recent publication which derived its data from the WHO database on gout and comorbidities. So according to this data, the incidence of gout worldwide currently is around 0.097% with a prevalence of around 0.54%. And as we can see in this graph, there is a linear increase of incidence as well as prevalence with aging until the age of 64 years, and then it declines, and then there is a second peak after the age of 80 years. As has been mentioned by previous speakers also, that the incidence and prevalence might be far higher in Asian countries such as India and Taiwan, and especially in patients above the age of 60-65 years, it can be as high as 9 to 10%. And so why is uric acid in children or young onset gout important? So there is coming up literature that says that children with hyperuricemia are more likely to progress to adult onset hyperuricemia. They are more likely to have adult gout, and also it increases the risk of atherosclerosis and metabolic syndrome in children. So that's the requirement for us to know whether or not we can do something about it, and what are the differences between a young onset gout and an adult onset gout. So we all are aware of the pathogenic mechanisms and the various interplay of factors that take place in gout. So we know we have dietary factors such as purine-rich foods, we have alcohol, and the serum-free fatty acids are known to activate the TLR receptor 2, further leading to formation of IL-1 beta. And also the complement coated MSU crystals, they can directly activate the inflammasome, leading to IL-1 beta formation. And also some interaction with netosis. And so basically it's a balance between the various pro-inflammatory factors and the anti-inflammatory factors. The question now arises is the autoinflammation difference in young onset and adult onset gout? So the current literature has not addressed this question as of yet, but yes, the genetic polymorphisms, as sir had also mentioned, there are a large number of studies which have seen mutations in urate1, NPT1, and even in GLUT9 in young patients. They have been reported more oftenly, but yes, they have also been reported in adult patients. But since adult patients have other risk factors also for gout, I think they tend to be more overlooked in adult patients. But as for now, we know that these mutations, especially urate1 and NPT1, are common causes of hyperuricemia in young patients. So the newer classification, the traditional classification, classified all gout patients as either overproducers or under-excretors. So now we have a newer classification which says that you can classify them as either a renal overload type, which can be further classified as an overproduction type, or an extra-renal under-excretion type. For example, ABCG2 dysfunction in the gut and in various intestinal diseases. Then we have the renal under-excretion type and the combined type, which have factors affecting both renal overload and renal under-excretion. So various causes of hyperuricemia in young. We have hyperproliferative states such as ALL or a tumor-lysis syndrome. We have inborn error of metabolism such as a Lesch-Nyhan disease or a partial HPRT deficiency, cyanotic congenital heart disease with secondary polycythemia, genetic mutations, infections, dehydrations, drugs such as valproate or theophylline, and even obesity. But when we come to factors determining renal urate excretion in elderly, drugs, I think, is one of something which is very common in the clinical scenario. So we have low-dose aspirin, thiazides, loop diuretics, we have NSAIDs and levodopa. Among renal causes, we have chronic renal failure, which can be due to any etiology, hypertension, and various endocrine or metabolic causes such as obesity, hyperparathyroidism, and even dehydration. This was a study done in CMC Vellore from Dr. Danda. So they looked at clinical profile of young onset gout in India, So they found that most patients were under secretors of uric acid with higher incidence of renal calculus. Polyarticular gout was more frequently in elderly and females, and it had a greater association with tophi, with renal calculi, renal dysfunction and ischemic heart disease. Diabetes, hypertension and obesity were more frequent in oligoarticular gout, and the young onset gout was characterized by acute intermittent polyarthritis. They had lesser episodes of podagra and they had early tophi formation. And then there was this another study from Taiwan who also looked at young onset gout, which they defined as age less than 30. So they found that the first attack frequently occurred between the third and the fifth decades in around 70% of the patients, and that the patients, females, even the incidence had increased in female patients. Coming to my last slide, which basically summarizes the main clinical differences between young onset and elderly onset gout. So the young onset gout is more frequent in females as compared to in elderly onset gout, which have almost an equal incidence between males and females, and especially in postmenopausal females. Asymmetrical lower limb involvement and a monoarticular onset is more common in young onset gout, while elderly people with gout can have a symmetrical or polyarticular involvement at onset. They can have upper limb joint involvement, and it can be of insidious onset also. The attacks of podagra, which are more commonly seen in young onset gout as compared to elderly onset gout, and tophi per se are rare in young onset gout and are more common in elderly onset gout. Thank you.
Thank you, Kirti, for that presentation. I'm supposed to give the words of wisdom, but I don't think I have any because I'm not really an expert in gout. If I may ask maybe Professor Terence Gibson to just tell us in this to us whether his experience in the management and approach to a person who has young onset gout. Sir, please. Can you give the microphone to Sir, please?
Well, the first step is to raise the question of why. And it's if a young person, we're talking about adolescents and children have gout, very, very important to explore the possibility of a genetic aberration, and then to look at the family. Just giving a bit of historical information, I was involved in exploring one family in the UK way back in the early 80s, and then we called it juvenile onset gout, and they all developed renal dysfunction, and these were patients who had a uromodulin gene deficiency, but at that time it simply wasn't recognized. It is perfectly possible that there remain genetic abnormalities, as I alluded to a little earlier, that account for gout as it crops up sporadically in populations. So first of all, look carefully at the family. Look to see whether there are any comorbidities, and look at the kidneys in particular. So having established that, and even the, so I may say that in the 80s, 70s and 80s, the theory was that these children were hyperuricemic, and the hyperuricemia was damaging the kidneys, not the other way around. And so the emphasis was on treating their hyperuricemia. It gradually dawned on us that as you got the uric acid level down, the kidney disease progressed. So clearly we got that one wrong, and that was at a time when it was held that hyperuricemia was damaging to the kidneys, and I know that idea was crept back into our discussion. But coming back to your question, it is possible in all these children to get the uric acid level down using allopurinol in a standard dose. So that would be my approach, having excluded any underlying genetic abnormality, explored that possibility in the family. So beyond that, they just need careful supervision with reference to the kidneys and the other organs too. But always keeping open the possibility that you're dealing with some new previously unrecognized phenomenon.
Thank you, sir.
Thank you, Professor. Can I have a follow-up question? So what happened with the, yes, to you, sir.
Professor Gibson, then Professor Sukumar Mukherjee.
Yep.
Okay, so what happened? So you got the uric acid fixed, and then they developed kidney disease. And did they identify what particular kidney disease was taking place? Did they do biopsies? Did they any nephritis that was identified?
Okay, so biopsies were undertaken, and of course, in early adulthood, all of the children in the family that I study had renal transplants successfully. Biopsies and the kidneys showed a lot of interstitial fibrosis, but there was no specific histopathological change that you could identify that made it, something easy to diagnose on the basis of a biopsy. So they just showed kidneys that were badly damaged. As I said, I outlined the history for you as best I could. It's uromodulin is an interesting molecule, and I'm not going to discuss that now, but if you go to the literature, you find it's a fascinating renoprotective part of the anatomy of the kidney, and when it's missing, this is what can happen.
Thank you,
Thank
sir.
you.
Can I ask a question?
Professor, please,
yeah,
then
so-
Professor Kumar Mukherjee first.
Sure.
Just a minute, please,
okay,
sir.
sure.
Sir, please. Professor Mukherjee.
Is there any threshold of serum uric acid with the formation of tophi? This is one. And second, I have got a very difficult patient of chronic kidney disease with the renal failure. And he is having recurrent gout in spite of the urate lowering therapy. How to handle this situation?
Professor Salman can answer that? Or you would like to answer? Yes, sir.
No, let's
Yes. Professor Lorenzo can also respond to that later.
Oh, that's great. Thank you. Thank you, Lorenzo, for helping me with these both difficult questions. The first one was, is there a threshold for tophi? And actually, I wouldn't say there is so many metabolic cofactors that affect tophi formation, and that's why you can find people with very high uric acid and they never develop tophi, and others it might be just sort of marginal elevated and still they develop tophi. No, I would say as an answer, no, out of at the time being. The other question was
Another question is the patient of CKD.
Yeah.
With a difficult to treat uric acid problem, gout.
Again, I don't have a ready-made answer for this. Probably I would tend to care for his CKD more properly, more sort of if he needs dialysis or not, if he needs his dietary.
No, that has been looked into. Actually, any drug therapy, particularly to control in spite of the...
Yes, but I don't have. Probably Terry has got an answer.
I don't necessarily have an answer, but in that situation, it's a very difficult one. A drug that's worth considering is benzbromarone, which is uric as uric, but it has an intense action and can work in patients with CKD.
Dialysis also, the patient is CKD.
It's not available.
For sure.
No, the clotting case, this is benzbromarone.
Okay, benzbromarone, yeah, we don't have it here.
So I just,
Yes, please.
leading to that, actually, I just wanted to ask, since many of the patients are actually under excreta, so it seems like the uricose uric is not in the picture anymore. Why is that so? And as what Professor Gibson has just said, benzbromarone can be used when the CCT is so long it's more than 30. So where do you come into play? Maybe the expert can answer that question. The other thing is with chronic tophaceous gout, I've one or two patients, and I do combine febuxostat with allopurinol at a dose of 160 febuxostat with allopurinol of 800 milligrams, and there is a difference. So the levels do go down, and I typically will bring it less than 300 micromoles per liter. And I was just asking the expert here, these drugs essentially are xanthine oxidase inhibitor. One is a purine analog and one is a non-purine analog. I've tried to look for the answer, and I don't know why by combining these two you actually bring it down. Maybe the expert here can shed some light on that. I mean, this is off-label use, but anyone have any comments or answer to that question? Thank you.
Well, with your first question, uric osurics definitely can be used. Okay, so we have probenecid and, as mentioned, benzbromarone. It depends on the availability in the country. Okay, and usually, I'm glad to hear that with benzbromarone, with chronic kidney disease, we can try to use it as a uric osuric. But we're also cautioned that we have to be sure, at least for probenecid, that the kidney function is good and intact. So we have it. I mean, you can use it. It's definitely available. With regard to your second question, I think we asked that combination of xanthine oxidase inhibitors for urate lowering treatment in the guideline, and we didn't get any answer. There was no data on it. And there was just little data on combination of a xanthine oxidase inhibitor and lesinurad, which is a uric osuric. Unfortunately, that drug has been pulled out of the market. It's not available anymore. But we just included it in our guideline because there was data on it, that it did have some effect, but it just wasn't available, but we had to put it. So I don't know. We asked that question and there was no answer to it. Thank you.
I think we can close. So we come to the end of the session now. I would like to thank all the speakers, Professor Gibson, Professor Salman, our dear Kirti, and my co-chair, and we'll hand over the session to the next team. Thank you so much. Never mind. But we had a good discussion. Thank you so much, sir.
It's so nice to meet you, Molly.
Molly.
Okay, thank you.